Good afternoon, everyone. I'm Dr. Mary Ambach. I'm joined by my colleague, Dr. Chris Rogers. Welcome to our Ask the Docs series. This is a 30-minute question and answer session where Dr. Rogers and I answer questions on regenerative medicine and innovative cell-based therapies for orthopedic conditions. We also include topics that involves any orthopedic injury or any condition that the public is interested to learn more about. So the topic for this session, this is our fourth session for this series, is knee meniscus tear and degeneration. You can go ahead and type in your questions using the Q&A button if you're joining us through Zoom.
They logged in with your account. So
Linda, probably log in.
That's fine, go ahead.
Or if you're joining us through Facebook, you can type into our comment section and we will answer the questions as they come in. If your questions are more of a personal nature, we would prefer that you call us so that we can discuss this in more detail. So I would like to welcome Dr. Rogers, and he can say a few things about our practice and the treatments that we offer.
Yeah, thank you, Dr. Ambach. I'm Chris Rogers. Dr. Ambach and I practice non-surgical orthopedic care here in Carlsbad in San Diego. Thank you for joining us. We have been treating sports medicine and orthopedic injuries collectively, I think, for more than 4 decades between the two of us. And the field is continually evolving. There are a number of new treatment options that we'll share with you today that are alternatives to some of the surgical options that are out there, as well as some of the non-surgical options that are out there. Today, as Dr. Ambach mentioned, we're going to focus on the meniscus. I brought along somebody's knee to just show you, for those of you who already don't know, this is the front of the knee. Your kneecap would be here, the side view, you can see that. Don't try this at home, but if we were to remove your kneecap and take a look inside your knee, you would see these 2 little semicircular structures. These are a specialized type of cartilage called fibrocartilage, and the structure itself is called the meniscus. And so this forms a little pad which does a number of things. Of course, it cushions the joint, as well as provides some stability to the joint. So by having this structure with these little concavities here, it provides a little stability to twisting in the knee. So you might hear that young athletes, soccer players, for example, may have injuries to the meniscus because they twist their knee. And so that's one type of injury. What we see more commonly in our practice are people who are older, who have chronic degenerative tearing of the meniscus. And these 2 injuries behave very differently. If you're 20 years old and you have a meniscus tear in the right part of your meniscus, a surgeon might be able to repair that. But typically, once you're 30 or 40 years old, a repair will not work surgically. It will not last. And so the surgeons now are agreeing that those should not be repaired surgically. Now, degenerative tears are extremely common. Meniscal tears in general are extremely common. If you take 100 people over the age of 50 who do not have knee pain, about 20 of those 100 people will have a meniscus tear on their MRI. If you take 100 people who do have knee pain, about 60 out of 100 will have a meniscus tear. It doesn't mean that the meniscus is the source of the pain, but it just shows you how common these tears can be. Generally, for older folks, surgery is not recommended, as I mentioned, even for a tear. There are a number of studies that show that surgery is not superior to simple conservative care with physical therapy. And so that's not recommended. Maybe Dr. Ambach, maybe you can mute wherever that background noise is.
Yes, I will.
Thank you, because I don't know how to do that. And so conservative care typically will consist of physical therapy to strengthen the knee, to help with the swelling in the joint, as well as restore some of the proprioceptive function, the balance function of the leg. Then there are things that can be injected into the knee, and that's where we're going to talk about some of the options that you might have for medical treatments for meniscal tear or meniscal degeneration.
I just wanted to add with what Dr. Rogers has said, the meniscus can be injured through degeneration, wear and tear, and this is typically a sign of cartilage degeneration and development of osteoarthritis. But they can also be acutely injured. Typically, the mechanism is a twisting injury on a bent knee. And most of these acute injuries occur at sporting events when there's a cutting or pivoting that requires knee flexion at high activity, or people who work or are in situations wherein their work involves repetitive kneeling or squatting or climbing. These are also risk factors for meniscus injury. So let's talk about the first question here, Dr. Rogers. One of the questions that I always get asked is, what is a meniscectomy and what are the outcomes with this surgery?
Yeah, meniscectomy, excuse me, whenever you have an ectomy, they're removing something. So an appendectomy, they would remove your appendix. A meniscectomy, they remove your meniscus. Now, in the 70s and 80s, it was a big surgery, and surgeons would often remove the entire meniscus, which in hindsight turned out to be a terrible idea, because once you remove that meniscus, you're now removing a significant part of the knee cushion function. And now you have more stress on the bone, in the thigh bone here and in the shin bone. And the next thing happens is the cartilage on those surfaces will start to wear down. And that, of course, is what osteoarthritis is when that cartilage becomes damaged. So the current thought now with orthopedic surgeons is to take as little meniscus as possible. And the vast majority of meniscus tears or degenerative meniscus tears do not require surgical repair, unless the patient is having significant mechanical problems. So the knee perhaps is locking. You can't bend the knee properly. You can't straighten the knee properly. Sometimes if the knee is unstable or if the meniscus is unstable, it can migrate out of the joint. Those often will require surgery. But the vast majority, more than 90%, will not require surgical intervention and can be managed with non-surgical care. In the past, we would inject steroid because why? Because steroid's a good anti-inflammatory drug, which decreases the inflammation in the joint. Turns out we have better options than steroid now, better in that it lasts longer, better in that it actually stimulates healing of the cartilage. So when I was in medical school, they taught us that the cartilage cannot heal or grow. And that never made sense to me, because I thought, well, when I was 12, my knee was a lot smaller than when I was, 30. And so obviously that cartilage can grow. It's just because it has such poor blood supply, especially later in life, it has a harder time growing and healing. But we do know that certain cells in your blood called platelets, or certain cells in your bone marrow or your fat called stem cells, can stimulate cartilage cells to grow. They can heal injuries. And they certainly can decrease pain and decrease inflammation. So these are some of the treatments that we now offer our patients.
Right, and the reason why we're so excited about these cell therapies is that studies upon studies show that meniscectomy, wherein you take out the portion of the meniscus, has no better outcomes than patients who are treated conservatively with physical therapy. It has no better outcomes than even sham surgery, wherein they put a scope into your knee and don't do any surgical procedure. And also, this patients who underwent meniscectomy has a higher frequency of proceeding with total knee replacement in comparison to patients who underwent physical therapy. So as Dr. Rogers has said, really the literature is pointing more towards preserving the meniscus as much as possible because of the early onset of osteoarthritis when you perform meniscectomy or meniscus surgery. Now, there are certain cases wherein meniscus repair may be indicated, and these are very, very select population of patients. Usually these are patients who are younger, who are active, who are healthy, who's got a small acute tear in their meniscus, and the tear is typically something that is in an area of the meniscus that has good blood supply. So unless you fulfill all these categories, it's most of these conditions can be treated conservatively rather than surgically. And that's where cell-based therapies and platelet-rich plasma come in, because not only can it help prevent the progression of the osteoarthritis, but it can even help improve the quality of the meniscus tissue. There's some studies that has shown that it did increase the meniscus volume, or it did regenerate meniscus tissue itself with before and after MRIs. And it also increased pain and function in patients who are regular patients, or even patients who are athletes. It has been shown that it did increase their sporting activity. So it's a non-invasive way to treat your meniscus injury with benefits of preventing progression of osteoarthritis.
Yeah, that's great. And so Dr. Ambach, we know that the meniscus doesn't have a nerve supply, right? Cartilage doesn't really have nerves or blood vessels growing. So if I tear my meniscus, why does my knee hurt?
So most of the time when a meniscus injury occurs, there are concomitant areas in the knee that's also injured, and not just the meniscus itself. As Dr. Rogers has said, it's very common for patients to have abnormal meniscus by showing meniscus tear or showing meniscus degeneration, but have no symptoms. So I think as clinicians, our first role is to determine, where is the pain coming from. And most of the time, if patients have coexisting osteoarthritis, most of the time the pain is actually coming from the knee joint itself, the cartilage degeneration, the inflammation in the joint because of the irritation from cartilage wearing out. Or concomitant soft tissue injuries like ligament sprain or tendon injuries, or even bursitis, which is the inflammation of this soft tissue around your bursa.
That's right. One of the more interesting studies that I had read over the past few years was a study performed in South Korea. And this was not a study for meniscus tear, but it was a study for knee osteoarthritis. And the interesting thing that they did was that they injected stem cells from those patients' own fat. So they took some fat through liposuction procedure and processed the tissue so they could extract the cells. Those cells were then injected into the patient's knee. And while they were injecting, they would look with a camera at the cartilage and they would grade the extent of the damage. Then 2 years later, they came back and would look inside the knee to see what changes had occurred. And only about a third of those patients had grown new cartilage. However, more than 80% of them had resolved their pain. So the point is that you don't need to grow your cartilage back. You don't need to probably don't need to heal your meniscus tear completely to get out of pain because of these other factors, the inflammation, for example, in the joint, which is the same reason why cortisone can be helpful. You inject cortisone, it calms down the inflammation. The problem with cortisone, it only lasts in your knee for a couple of days, and the effects may only last a couple of months. Whereas if you inject cells from the fat or cells from the blood, we can get years of relief from a single treatment.
Thank you, Dr. Rogers. Next question. It's a two-part question by one of our physical therapists regarding PRP injections to address degenerative meniscus tears. Excuse me. Number one, is it uncommon or unusual excuse me, for active individuals to require multiple PRP injections to address this condition? I'm sorry.
Yeah, I can take over while you choke to death. Is it unusual or common or uncommon? So this is still debated amongst our colleagues. There have been a number of studies that have looked at PRP. So PRP stands for platelet-rich plasma. That's where we centrifuge the blood and concentrate the platelets and inject those into the joint. There's been debate whether patients should just have one treatment or if they should have multiple treatments. The vast majority of studies show that typically one treatment is sufficient to get anywhere from 9 to 12 months of relief. There is only one study that I'm aware of where 3 injections was superior to 1 injection, but the other 90% of the studies generally don't show that finding. In our clinic, we're cost conscious, so we generally just provide the one treatment, and then if the patient, let's say you get 50% relief, well then maybe it makes sense to repeat it at 3 months or whatever time period we think is appropriate. If you don't get any relief, then at that point we say, well, probably it's not going to provide additional benefit to repeat it, so let's think of some other option. That's the first part of that question.
That's the first part of the question. Yeah, unfortunately, there's not enough data to support the ideal number of treatments. If you think about the meniscus, they divide the meniscus into 3 regions. There's the periphery or the outside portion, which has the good blood supply. Dr. Rogers is showing you. And then the middle portion of the meniscus, what they call a red-white region, which is less blood supply. And the innermost portion of the meniscus, what they call the white region, does not have a good supply. So if your tear is more located on the inside of the meniscus, because there's limited blood supply, it's harder for those tears to heal. So intuitively, you would think that maybe those kinds of injuries might need more injections, and usually that's what I have been finding. However, again, there's really no data to support what's the ideal number of injections for meniscus injury. So related to that question, the second part of the question says, if diagnostics like MRI reveal tear location not only at the periphery, but more so in its interior concavity, can PRP reach these inner regions?
Yes, a great question. So location is important. We consider many things when we decide what might be best for our patient. We look at the degree of the injury, right? So it may be in an area where the blood flow is not as good, but it might be so small, or it might just be a little roughening of the meniscus that's not going to be a huge issue. We look at the stability of the meniscus. Like I said, sometimes the meniscus becomes unstable. There are little ligaments called the coronary ligaments, which hold the meniscus down to the bone. There's also on the side of the knee, there are these collateral ligaments. This is called the MCL, the medial collateral ligament. Sometimes there are tears in the ligament. Sometimes there's separation between this ligament and the meniscus. So each person is unique, and we try to address each area. But at this point, I would say that other than those individual characteristics, to answer the first part of the question, I would say more than 90% of our patients just receive a single treatment, and that seems to suffice. So the more troubling meniscal tears, they may require additional treatment. One additional treatment I'll just tell you about, you can Google this, I was just pulling it up. One of our colleagues, Dr. Malenga in New Jersey, published a paper in the Journal of International Orthopedics, where they used cells from the fat and injected those directly into the meniscus tear, and they were able to show that more than 60% of their patients were doing well at 1-year follow-up with that single injection. So there aren't very many studies that look beyond PRP, that look at cells from fat or cells from bone marrow, but this is one of those early clinical trials that suggests that majority of patients can improve with cells, and these were larger tears. So these were patients that were not considered PRP candidates.
That's right. So I want to backtrack a little bit. All of our patients are educated on these cell therapies. We're assuming that everybody knows what PRP and cell-based therapies are. But for those of you who don't, PRP stands for platelet-rich plasma, and this is a concentrated solution of platelet cells that contains thousands of growth factors. And these growth factors are the ones that stimulate cells, stimulate blood vessel formation, they encourage tissue regeneration, and they decrease the inflammation. The other cell therapy that we use is what we call cell-based therapies, and these consists of a different set of cells that are derived from either your bone marrow or your adipose or your fat cells that are also involved in healing and repair. And by these mechanisms of decreasing inflammation, stimulating tissue regeneration, tissue repair, decreasing inflammation, fighting infection, and increasing blood flow, these are the ways that it can help meniscus tear, meniscus damage, and concomitant osteoarthritis that comes with a degenerative meniscus. So one other question, Dr. Rogers, that we always get asked a lot with regards to these therapies, are these therapies safe, PRP and cell-based therapies?
Yeah, that's a great question. And that's the first question you should always ask. If some doctor says, I have this new treatment, that's wonderful. You should ask them, well, what safety data do you have? Other than the fact that Dr. Ambach and I together have treated multiple thousands of patients and have not experienced any serious adverse events, the published scientific literature also shares that same experience. So thousands, if not tens of thousands of patients in the published scientific literature, specifically with regard to PRP, cells from bone marrow or cells from fat. The longest study was correct me if I'm wrong, Dr. Ambach, I think it was a knee osteoarthritis study where bone marrow cells was injected, and they followed these patients for more than 12 years.
That's correct.
With repeat MRI, not just of their knee, but of other parts of their body, looking for tumors, looking for other problems, and not finding any. So we feel very comfortable that this is safe. And I personally think it's safer than taking Advil every day, because Advil is associated with complications such as gastric ulcer, hypertension, renal, kidney issues. So fortunately, these are safe. Now, mind you, we are using your own cells, right? So we are aware that there are clinicians in the United States who purport to use somebody else's cells. And you should just know as a patient that that's not allowed. That's not legal. The FDA does not permit it. And there's risk of contamination. There's risk of disease transmission. However, when using proper techniques, collecting your own fat, your own bone marrow, or your own blood, I'm in the lab. You can see we have this sterile hood behind me. So we have our standard operating procedures that our staff follows to make sure that we are minimizing any risk of contamination and that we are providing safe therapies. So the safety record is very good. When we talk about safety, we talk about something called adverse events. So did something bad happen? So whenever you're watching TV and you see a drug commercial, they talk about, the long list of, may cause hair loss, may cause, infertility, all these things. They're obligated to report these adverse events that occurred during their clinical studies of that drug. Those adverse events are ranked as mild, moderate, severe, serious. In the cell therapy literature, generally you only see mild adverse events such as pain or swelling for a few days, nothing more than that. I see that somebody wants that reference. Can I just get ready? If you know how to do a screenshot, I will flash the Dr. Malenga's article. If you don't get it, let me know and I'll just email it to you. But if you screenshot that and then Google that text, that's probably the quickest way to reference that article for you to read. The other option you can do, which I think is great for those of you that are really great junior scientists, go to a website called pubmed.gov, pubmed.gov, and you're paying for it. As a taxpayer, you pay for pubmed.gov. It's the National Library of Medicine. It's all the published scientific literature. and it works like Google. Once you end up on PubMed.gov, just type in meniscus tear PRP or meniscus tear stem cells, and all the published scientific papers will pop up, and you can read them. So that's great, because in the old days you had to go to the library and look up the.
Gone are those days.
Yes.
Libraries are closed now too. So we have about 5 minutes, and we have time for a few more questions.
Okay.
But while we are waiting for more questions here, I wanted to inform you that we do this question and answer sessions every first Wednesday of the month. So you can join us either through the link that you were sent through email or through Facebook posts. Or if you liked us through Facebook, you will get automatic notifications when we have these Facebook live events. And you could just go to our home feed and join us live through Facebook. Also, we for those patients who are interested in getting more details about these orthopedic conditions or the different innovative therapies that we do webinars every second Wednesday of the month, wherein we take a longer time. We take about an hour to discuss specific topics on regenerative medicine, and we've got pictures and slides for you to inform you about all these exciting treatments. And for those of you who miss our live events and our webinars, we do keep a recording of these sessions in our YouTube channel. So if you type in YouTube and type in the name of our practice, San Diego Orthobiologics Medical Group, you can see all the videos that we have of our prior events.
So Dr. Ambach, we have 3 minutes left and 3 questions just popped in. So I'll zip through the first 2 and I'll let you take the last one.
Okay.
First question says, I have heard that some companies use placenta stem cells to assist with healing. Can you comment? So yes, as I told you, it is illegal to use somebody else's cells for any application other than the fact that you may have stored your children or grandchildren's umbilical cord, but the only person who can use that umbilical cord blood derived stem cells would be that child. So there have been problems with companies selling these products, doctors not being well informed and injecting them in the patients, and then these patients get infected because the samples are contaminated and those patients have ended up in the hospital. So my general advice is to avoid those companies, avoid those doctors. They're either uninformed or just not sharing the truth with you. You can travel to Mexico, you can travel to Panama, you can get somebody else's stem cells. Other countries it's legal. It may or may not be effective. Those companies generally don't post their outcome data. They don't publish papers, some of them. So we can't comment until we have published data in the peer-reviewed medical literature. The costs, we're all concerned about costs, and we try to offer the least expensive option that makes sense for a patient. Insurance companies don't pay for these yet. There's a lot of reasons why. Many of them are just the uncertainty of it. They don't like the uncertainty. Even though we have published studies showing the effectiveness, PRP for certain indications, is still not covered. So hopefully that will change in the future.
I'll let you take this next question, Dr. Rogers.
The last one?
By Rick. Does PRP travel and work on other parts than the injection area?
Oh, yeah, great question. So as far as we can tell, PRP does not travel, meaning if I inject PRP into a tendon or into the meniscus, it'll pretty much stay local. Interestingly, there have been studies done where you inject stem cells from fat into a joint, and even though the cells do not leave the joint, they secrete molecules that may leave the joint and get into your bloodstream. And there have been studies where if you look at inflammation in the blood, it actually is diminished probably by these molecules that are secreted by the stem cells in the knee joint. That effect seems to last for about 3 months and then it fades away. So we're pretty confident the cells do not migrate beyond more than a millimeter or 2. Stem cells, interestingly, can crawl around and walk to sites of injury, but they probably can't walk very far.
Right. And Rick, if you are concerned about systemic effects like patients with history of cancer, there has been no studies that have shown that PRP can actually stimulate the proliferation of abnormal cells or stimulate the formation of cancer cells. It has been safe based on, as Dr. Rogers said, many years of safety data.
Having said that, if our patient has lymphoma or some other blood cancer, we generally will not offer PRP to that patient, just not because there's any evidence to suggest that it's unsafe. It's just it's not fully known yet, and we're not gonna take that risk.
All right, last question. If there's already bone deterioration, a joint from arthritis, does PRP help? There's different kinds of cell therapy that we provide in the clinic. As we have mentioned, when your arthritis is mild to moderate, PRP does a great job in improving your pain and function. However, when your arthritis is more severe, more in the moderate to severe category, that's when you start to see bone involvement, either through edema or swelling or deterioration. And the cell-based therapies are more effective in helping these conditions than platelet-rich plasma treatment. Great questions at the last minute.
Yeah, thanks guys. You came through with some good ones there. I'll just tell you, some of the first uses of PRP back in the 80s with Dr. Marks was trying to heal bones that were having trouble healing. So he was injecting PRP into bone fractures in the face. He was a maxillofacial surgeon, is still alive, who was able to show that he could heal bone by injecting PRP in the bone. So there is evidence for that. But like Dr. Ambach said, if you have bone involvement, we're probably going to offer something else other than PRP.
Thank you, everybody, for joining us. And thank you for sitting in for 30 minutes. And we love your questions. Keep them coming. We'll see you on March 3. That will be our next Ask the Docs series. Till then,
Bye.
Take care. Bye-bye.